simple. I don't try to, you know, he'll talk about the interaction between this and that and this and that, and I just never see that. So I'm gonna give you the basics. Let's get good at the basics, and if you wanna learn more of this, you could take a continuing ed course or get a mentor who's a good foot and ankle person. So the talocrural joint, let me get a model here.
You're here. She lets you leave the house.
It's just
Let's have fun.
okay.
Maybe. I don't know. Sleep. I'll do it. Let your wife fix it. Well, you don't like it? Stick it over.
All right. Talocrural joint, articulation between the talus and the tibia, distal tibia and distal fibula. Okay? Hinge joint, make it really simple. You're just going to provide dorsiflexion and plantar flexion in what plane?
Sagittal.
Sagittal plane. Correct. Firm infield. So when you come up into dorsiflexion, it feels firm. Same for plantar flexion's a little, got a little spring to it, but pretty much a firm infield both ways. Motions occur around an oblique axis. Okay, this is where it gets crazy, because again, you've got all these different articulations here, right? This is not like our elbow that does this. But if we're looking strictly at talocrural, we're going to talk about dorsiflexion, plantar flexion in the sagittal plane. Right. So that neutral position is essentially a right angle here. Okay. That's where we're going to be. That's where we get pretty good congruency right there as well. Right. So that's where we can do some. It's not quite a closed pack position. It's a neutral position. We can do some mobilizations there. Again, we'll talk about more this summer. Subtalar, this is where it gets much stickier. Synovial, condyloid joint. Infirm is infield is firm, hard in inversion. So 3 separate articulations between the talus, the calcaneus. Okay, you've got all kinds of interplay between these, right? So if we look at, again, motion's going to occur around this oblique axis, inversion. So here is the foot. And if we're going to invert the foot, which is turn it this way, everybody would agree with that, right? If we turn it to the inside like this, that's inversion. That is going to be calcaneal adduction. So you can see the calcaneus go towards the midline. That's adduction. Along with supination, just like in the forearm, palm is up, arch is up. Supination and plantar flexion. In order to invert, you're going to have to, you can't be in an everted position, or excuse me, in a dorsiflexive position and supinate or invert your foot. So there's going to be a degree of plantar flexion with that as well. Everybody take your foot and turn it in like that. Can you see all these things? Can you feel these things? Calcaneal adduction, supination, you're turning your palm up, and plantar flexion. Is your toe not pointed more down than up? Everybody agree with that? Can feel that, see that, all right? So we're looking at just the opposite for eversion. You've got calcaneal abduction. So here's our eversion here. We take a string to the outside of your pinky toe and pull it out. That's your eversion. And that's going to be calcaneal abduction, pronation, and dorsiflexion. Combination movements. All right? We can't go any further until we all get this. Does it make sense? Combination movements, okay? Again, talocrural joint, dorsiflexion, plantar flexion only. This one, much more complex, much more complex. So if you have an injury to the subtalar joint, a severe sprain, a fracture, a bone spur, all of these things have to be considered, okay? It's really tough. This is tough to measure, tough to treat, all of these things. Are we okay here? Because again, we cannot go further unless we understand this. Everybody's good? All right. So if we move distally, we've got, just like in the hand, wrist and hand, same type of thing. You've got transverse tarsal or mid-tarsal joints, okay? That's gonna be right here. You've got tarso-metatarsal joints. So we go down from the metatarsals to the tarsals here, all right? Again, that's pretty much just gonna be flexion and extension. And then metatarsal phalangeal joints, as we move distally, exactly like the hand. Exactly like the wrist and hand. Just replace tarsals with carpals for that, all right? Not that difficult. We do have two sesamoid bones at the first MTP. We talked about those yesterday. And again, 2 degrees of freedom, flexion and extension, and just like the hand, we can go ABA deduction as well, all right? Can y'all take your toes and splay them? Yep, bring them together, flex them, extend them, all right? That's all we're looking at there. No rotation, thank you. You will see these terms as well. Hind foot or rear foot, okay? That's gonna be talus, calcaneus for the most part. Midfoot, that's gonna be your what? What are these bones? Tarsals, right. And then the forefoot's gonna include the metatarsals, okay? The dome of the talus. That's where we said the articulation is between the tibia and the fibula here. The dome is here, okay? So if you get a, who was asking about a high ankle sprain? You were asking about a high ankle sprain. So that is an injury between the talus, the tibia, and the fibula right here, okay? In this called syndesmosis. It's a joint, per se, between the two. And that gets usually with massive dorsiflexion. It's a mortise joint. Y'all know what a mortise is? Like you jam something up in here. That's what we've got. Basically have two uprights here. Fibula, tibia, and you've got a triangular type of shaped bone here, and it's just wedged up in here. And if you wedge it too far with a twisting motion, you're gonna have injury here. That's that high ankle sprain. And it's very hard to heal because there's very little blood flow there, okay? Anybody seen one of those, had one of those? It's pretty common nowadays, it seems like. When it's not like an automatic 6 weeks out for athletes and all that good stuff. Sinus tarsi, okay. So, when you have sprained your ankle, and especially when you were talking about where that swelling comes up, that is in the, quote, sinus tarsi. That's where the fluid collects. That's right here. If you're coming right off that anterior talofibular ligament, just anterior to that, there's a gap. There's a big gap right there. And you guys can feel that. If you go just in front of the the lateral malleolus, there's a gap. And if you sprain your ankle, that's what fills with fluid, the sinus tarsi, okay? The navicular tuberosity, we talked about that. Most medial, most prominent bony part there. The cuboid, we've already talked about this, and medial cuneiform. Base of first metatarsal, dorsum of the foot, pretty easily there. Base of fifth metatarsal, we talked about how that fracture occurs very often, okay? So this is just some basic stuff. Most of that we've already covered. Stop me or slow me down if we need to. We talked yesterday about the deltoid ligament. This is medial. This is what it's going to look like, right? All these come down to that sustentaculum tali and provide. What does this prevent? Inversion or eversion?
Eversion.
Eversion. It prevents excessive eversion. Okay? Whereas if we look laterally, and we see this anterior talofibular ligament, again, this is where that sinus tarsi is going to fill with fluid. Anterior talofibular ligament, posterior talofibular ligament, and then the calcaneofibular ligament here. Those three make up and prevent what? Inversion sprain. Okay? Any questions there? Sustentaculum tali, okay? 2 to 3 centimeters directly below the medial malleolus. It's just a little ridge is all it is. But it's very important because this is where everything is going to attach here. And then right, you got Tom, Dick, and Nervous Harry coming down this way. So above that's going to be ligamentous. Around here is going to be, what do you got? Several tendons, nerve tissue, artery, vein. Okay? So a lot going on right here. A lot going on right here. Arches. Talked a little bit about this the other day. The medial arch is the one we think about when we say the arch of the foot, right? If someone has a fallen arch or what have you. Majority of shock absorption, you know, when you jump off of something, your foot is basically a bag of bones, if you think about it, held together by a bunch of ligaments and muscles. It is conforming, right? When you fall, your arch falls temporarily and it springs back, okay? That's due to the ligamentous structure here. This can get stretched. Now, someone with really flat feet, is that going to be as accommodating? Mm-mm. They hit and all that shock goes up back through their body, okay? If you've got somebody with an exceptionally high arch, and we'll talk a little bit more about this too, there's 2 terms for this. Flat foot. Gracious, what are y'all doing?
Traction.
You should do a castle.
Traction. Math. Oh, I love it.
Oh, and show it like that.
Joe PT.
With all the combinations on
Mm-hmm. All right. All right, 2 terms denoting arch height, okay? Pes cavus is a high arch. Pes planus is a flat foot or a low arch. I think this is pretty easy. A cave has got a rounded, right? So you got to go through the under the cave. Plane is very flat, right? So that's a flat foot. If you've got somebody you see in a chart that they have pes planus, you're thinking this person has flat feet, probably increased valgus at the knee and internally rotated to the hips. You can almost assume that every time. The pes planus club up here, okay? Does anybody have a really big arch in here? I didn't see any that I thought were. So if you're walking on the beach and you can only see the outside of your foot in the sand, that's a pes cavus person, okay? Their arch is rigid. This part right here doesn't conform. You're not going to see that nearly as much as you're going to see the pes planus. So, who of these 2 is going to have more inversion ankle sprains?
Cavus.
Pes cavus, because they're already on that outside of their foot. and it's really easy to roll that over. And you've got pes planus and chronic ankle sprains inversion.
But that was like landing on.
That was just landing, exactly, kind of flukish thing, yeah. But people who have pes cavus tend to walk on the outside of their foot and stay in inversion. So therefore they are more susceptible to those injuries. Pes planus, again, flat foot, valgus knee, medial knee pain, patellofemoral pain, and internally rotated hip.
So could you use it like with patient education?
Yep.
Like encouraging them to use like better shoes and stuff?
What kind of shoes would you get them?
I don't know.
We'll have somebody that comes talk about shoes and stuff. But somebody like these two up here who have really low arches, they need lots of medial support so they don't completely bottom out. Okay. Motion control shoes is what they call
They
them.
never would let me wear flat shoes.
That's right. That's right. Don't wear flip flops.
I hated it.
Like when you walk around the house in bare feet, your feet hurt, don't they?
Sometimes.
Yeah, doesn't feel very good. Doesn't feel very good. As opposed to somebody who's got this big cave, big arch, they've got to have lots of medial posting to bring that up to keep that space. Okay. And again, you can talk about shoes for days. You've got all these different types of running shoes and all this stuff, and we'll bring somebody in to talk to y'all about that this fall. Does this make sense? Again, I'm not very smart when it comes to feet, so I try to break it down really simple. Transverse arch, that's the one that's running this way. This way. From the first metatarsal to the fifth metatarsal, okay? That longitudinal arch support, these this way, supported by these ligaments. We talked about the spring ligament yesterday, long plantar ligament, plantar fascia, all that stuff on the bottom of the foot there. Extrinsic muscles can help with that. They create a stirrup effect. Everybody know what a stirrup is? Okay? So you can think about all these muscles that start up here and come around and wind down and around. They provide some stability there. Okay? Not a whole lot. Not nearly as much as the bones and the ligaments do, but they provide some amount of stability. So if you've got weak muscles or for some reason a torn muscle or something like that, you're not going to have as much stability there. But it's more about the ligaments than anything. Intrinsic muscles, we talked about those. All those muscles in the bottom of the foot going in different directions, again, create this type of web that gives you some support there. Very intricate network. So more, long plantar ligament runs from the calcaneus to the cuboid, deep to the plantar fascia. Talk about the nerves a little bit, muscles of the big toe, muscles of the little toe. I told you you don't need to worry too much about that. And then you've got that central muscle group, those lumbricals, flexor digitorum, all these, again, you just know the actions and you're gonna be fine there with that. Tom, Dick, and Nervous Harry, we've been through that several times now. Again, what is it running below? Around the medium malleolus, below the little ledge. What's the little ledge? Sustentaculum tali. Okay. Anterior tib, primary dorsiflexor. Again, we talked about the origin insertions and all that type of thing. Extensor hallucis longus, digitorum longus, and brevis, all are anterior. Okay. Lateral, we've got fibularis, or what's the other name for that? Perineals, longus and brevis. These are the everters. Okay. Gastrocnemius. Two heads, right? comes down with soleus to form the Achilles tendon. Soleus is deep to the gastroc. Those two have 3 heads. What is that called? Triceps surae. Still up there. Posterior tib originates on the tibia and fibula, runs under the foot, inserts on the navicular, so it comes medial. If it inserts medially, what does its action have to be? It's got to be an inverter, okay? We know that anterior tib is going to dorsiflex and posterior is going to plantar flex, but again, the inversion and eversion is based on what side of the foot that it inserts. The perineals are going to be everters as they're lateral. Here's the nerves. We saw this the other day. There's some really quirky stuff that happens with nerves in the feet. Has anybody heard of a Morton's neuroma? That is a group of nerves between the between the 3rd and 4th digits of the foot, and it's usually on the plantar surface, and it becomes very, very painful. It's just a group of nerves, clump of nerves, if you will. People, every step they take, they have this nerve pain. So what do they do about that? They will inject it first, and about 50% of the time that works and calms everything down and they can move on about their day. If that doesn't work, they just go in and cut the nerves out. Because again, it's just a big bundle. I don't even really know the purpose of them, but they only are good to cause pain, and that's right here. And they'll go through in between the toes, make an incision, and just take the nerves out. You're not going to usually see them post-operatively for something like that. It's just sutured up, and they put them in a boot and go on their way. All right, ankle joint goniometry. Not easy, not easy. So we've got dorsiflexion. You know, we said we started 0, right? We said it was a 90-degree angle here, so that's our 0 point. We've got about 20 degrees of dorsiflexion. We've got about 50 degrees of available plantar flexion. Now, if someone has tight heel cords or tight gastroc soleus complex, heel cord is another name for this. If they have that, what are they going to be limited in? Dorsiflexion, okay? Not many people are limited in plantar flexion, much more so in the dorsiflexion. Inversion, eversion. Inversion is about a little bit more than twice the amount of motion there. About 35 degrees this way and only 15 degrees that way. I think you can probably see that or feel that when you guys do that yourselves. Now, how do we get those measures? Our axis will be our lateral malleolus. Stationary arm, lateral midline of the fibula with the fibular head as the reference. So you're going to line that up along this way. Your moving arm will be parallel to the lateral aspect of the 5th metatarsal. You will not be able to put it on the 5th metatarsal, okay? Because the axis, this is what's frustrating the students. It would be so nice to line something up here and then line it up down here, okay? But the axis occurs here. So this moving arm will need to be parallel to that. Yeah, you'll sit on the top of it, if you will, right. So here's the bone, here's the axis, your moving arm will be like right here. And that's what's really difficult. You've got to make sure you know what that 5th metatarsal looks like and where it is anatomically, okay? That's a 0 position right here. It looks like 90, but we call that 0. That's going to be roughly 20. That's going to be roughly 50. This is a tough measurement, but one that's really important. how much, I know you guys don't know much about gait yet, how much dorsiflexion does it take to walk without a limp? Take a guess. It's about 10 degrees. If you don't have that 10 degrees, you're gonna walk like this. And you see this all the time. People who are really tight or have had surgical procedure and never get that motion back. So you're gonna measure this a lot. It's important. You can measure this in supine, you can measure it in sitting. I don't really care. Whichever way you can make sure. See how this arm is parallel to this? Every time I want students that they want to bring the axis down this way. Don't do that. Leave the axis right there and let this be parallel to that fifth metatarsal. See the difference here? Because if you start moving that axis, things are going to get really messed up. This one's even harder. You remember measuring ulnar and radial deviation? Well, now we're going to do that with some supination and pronation. It's awful. So our axis, anterior aspect of the ankle midway between the malleoli. Not that hard to find there. Stationary arm, midline of the tibia. That's also pretty easy. Here's where it gets difficult. The moving arm, anterior midline of the second metatarsal. It's pretty easy to line up, but you're going to see how frustrating it is. Number one, you're going to have to use a smaller goniometer. You can use a big one, but it's not going to work very well. But you have to use a smaller goniometer. You got to make sure that this axis stays right in between the two malleoli there and keep this aligned with the second toe. Okay? It is not easy. 35 degrees roughly of inversion, 15 of eversion. Quick. Inversion. What are the three components of inversion? Calcaneal adduction, supination,
and plantar flexion.
plantar flexion. Okay? Eversion.
Adduction.
Abduction,
Pronation.
pronation, dorsiflexion. Dorsiflexion. Okay? Combination movements. Really cloudy. First MTP joint. Important. Again, how much dorsiflexion or how much extension of the great toe do you need to walk without a limp? You don't need quite this much. You need about 30 degrees. Okay? So if you've got a really stiff big toe, you've got somebody that's not going to be able to walk right or run right. That happens all the time. First ray mobilizations, I'll show you all that this summer. That's when it gets fun. So flexion at first MTP joint is about 30 to 45. Extension roughly to 50. AB and adduction, you're not going to measure that. There's ways to, but you're not going to measure that.
What are the normal ranges for dorsiflexion and plantar flexion?
Dorsiflexion, plantar flexion, 20 degrees for dorsiflexion, plantar flexion, 50 degrees.
Okay.
Yes, ma'am. That was correct, yeah. 20 and 50. 50 seems like a lot. You know, you'll see some people that can look like a ballerina and have 70, 80 degrees, and some won't have that much. There's a lot of variability there. But this one, 0 to 20 is pretty consistent. Again, small goniometer for this. You're just going to place it on the MTP joint and just line up the arms with the bones above and below. Pretty simple. But you don't need to worry about AB and adduction. We will not measure subtalar joint rear foot inversion, eversion. That's something you do in prone when you're looking at the calcaneus. If you want to look at it in the book, feel free. Or this transverse tarsal joint inversion, eversion. Very difficult to measure. I want you to get the basics down. Gastrocnemius muscle length. Similar to what we did when we were measuring hamstrings. You're just gonna measure dorsiflexion, but you're gonna do this with the knee what? The knee fully extended, okay? As soon as you bend that knee, you're no longer measuring gastroc, you're measuring what at that point? Gastroc crosses the knee joint, so if we straighten it, it's gonna put it on stretch. If we bend it and then measure this, what are we actually measuring? You're measuring soleus length at that point. Okay. That's the way you stretch them. Let's go work on some dorsiflexion, plantar flexion. I'm gonna leave this one up. Hang on.